All right. Hi, everyone. I think we're ready for our scientific session number 3, Discovering Impactful Biomarkers to Improve Gastric Cancer Prevention. I'd like to introduce our first speaker, Meira Epplein. Dr. Epplein is a co-leader of Cancer Risk Detection and Inception Program of the Duke Cancer Institute and professor of Population Health Sciences and Medicine at Duke University. She's a cancer epidemiologist interested in modifiable risk factors in underserved populations with a focus on the association of infection and cancer. Specifically, her research seeks to further our understanding of the diversity of bacteria Helicobacter pylori, host response to infection, and the association with gastrointestinal cancers. She's also involved in local initiatives to understand the prevalence of Helicobacter pylori in the community and to explore the opportunities for precision prevention of gastric cancer through targeted Helicobacter pylori eradication therapies.
Thanks, Haejin, and hello, everyone. I'm going to echo what everyone else has said. What a great meeting. And I've been a gastric cancer epidemiologist for about 20 years, and I so appreciate all of you guys who've been doing that longer than me, but I'm really excited about the new young people who are going to do it after us, during us, and keep moving this forward. So really excited to talk to you today about CagA and gastric cancer interception. So I'm just going to take a step back because a lot of people have been talking about interception. And let's just give credit to Elizabeth Blackburn, the Nobel Prize winner, who actually really redefined this back 13 years ago. And I love her football analogy, right? So in panel A, cancer has started the carcinogenesis process and then it lands, touchdown, cancer. And her point is, why can't we do active interception in the pre-cancer space? So that's what cancer interception means to me. And I think from the football to the intercept guy, don't want to speak football language, obviously. We've all been talking about this, where to intercept. Is it among younger people with H. pylori? Is it once you have gastritis, intestinal metaplasia? Is it early cancer? So I think this is what we're trying to think about here. And I'll put it, obviously, with CagA, which is what I was asked to speak about. But I want to mention, as Haejin also noted, I lead this cancer risk detection and interception. It's a new program at Duke Cancer Institute focused on this interception word. So if we think about the continuum of factors leading to cancer, and that cancer is typically diagnosed between invasion and metastasis, what we're doing in our program is on that left side of the fulcrum, right? Where can we intercept cancer, and what are the ways that we can do that? And so obviously H. pylori, we're all a believer that this is a potential interception mechanism. So at Duke University in Durham, North Carolina, our patient population, the diversity is African American. We have some Asian patients, not a lot, some Hispanic, but really it's African American. So if we look at the CagA cascade for the 50th time today, and we think about that long span of time when eradication therapy reduces risk, what's really interesting is at Duke, overall our patient population is 19% African American, but among those with H. pylori positive non-atrophic gastritis, 48%. Among those with H. pylori positive intestinal metaplasia, 57%, and then 62% of our gastric cancer cases are African American. So that just happened in 2018 that we started seeing more Black gastric cancer cases than white gastric cancer cases. So this is a really interesting place to do this work. I want to mention, too, that obviously, as everyone's talked about, it's not just a black-white disparity. This is work by Mercedes McMahon and Jennifer Ye that they kindly shared with me their scoping review on H. pylori seroprevalence. So again, just highlighting, obviously, there are higher rates of H. pylori seroprevalence in all non-white groups. And I think something, to me, that's really important about this is that it's not necessarily going away over time, especially among the non-white high-risk groups. So here you can see their oldest birth cohort, and very clearly in green, the non-Hispanic whites having the lowest H. pylori seroprevalence over time. But even in their youngest birth cohort, there the non-Hispanic whites have the lowest seroprevalence, but we still see higher in Hispanic and Black, and definitely in American Indian, Alaska Native, and it's blank in the Asian Pacific Islander, and that's really important too. They didn't have data to be able to talk about young Asian Americans and Pacific Islanders. So this is, again, really important data that we collect and understand. So going to talk about CagA, and so of course I went to Rick Peak, who's not here today, but he gave me this slide. I think most of you guys know that CagA is the most well-established virulence factor. It utilizes a strain-specific type 4 secretion system to translate CagA, an oncoprotein, into host cells, and it induces pro-inflammatory cytokines as well. So we won't get into mechanism. I'm an epidemiologist, but just to acknowledge the role of CagA. So the first work I started doing in CagA and underrepresented populations was using the H. pylori multiplex serology from Heidelberg, the German Cancer Research Center. And they've been fantastic collaborators. So they have a multiplex serology. If you haven't used it, it's fantastic. It requires only a very small amount of plasma or serum. Right now, they're looking at 13 H. pylori proteins, including CagA. And so the first thing I did, I was at Vanderbilt University before coming to Duke, and the fantastic Southern Community Cohort Study, which you may not be familiar with, but it's a fantastic study that really represents folks that aren't represented in any other study, low income, primarily African American, in the Southeast United States. So at the time, we were thinking in the US, H. pylori rates about 30%, highest rates in Japan and Korea. And we saw amazingly high rates in a subset of our Southern Community Cohort Study. So 90% of our Black participants had antibodies to H. pylori, and 70% of our white participants, again, very low SES, so over half of this population have less than a household income of $15,000 a year. But where you see the real disparity is in that CagA H. pylori, right? And we know there's a disparity in gastric cancer incidence and mortality by race. Is it about CagA? So some other work we were able to do was look at antibody response. So that's the nice thing with the multiplex serology assay. You actually get a quantitative value of the antibody response. And we saw that among our white and African American participants in the study who are VAC-A positive and CagA positive H. pylori. There was a significant difference in that antibody response. Could that mean something? And so this is the actual models looking at the association of being Black compared to being white, and then being in higher and higher quartiles of CagA antibody response. So model C, which I'm highlighting here, shows a 4-fold increased risk of being in the highest quartile of CagA antibody response if you're Black versus white, with a significant adjustment. And what does that mean? So does this dose-response association, it could be an indicator of those with active infections. So this is a study where we actually had people who had taken the breath test as well as serology and compared the two. And VAC-A actually was particularly good, the quantitative levels at telling us what's a current infection. But CagA was pretty good as well. So it could be that's an indicator of an active infection, these higher antibody levels. It could be a more pronounced infection and inflammation. So I'm thinking about intercepting gastric cancer, getting back to the football analogy. So, some people are concerned that H. pylori is disappearing in the US, and so we don't need to intercept. So we found in 4 large cohort studies that H. pylori is not disappearing for our non-white participants, and specifically for our African American participants. So here, because my talk is CagA, these are prevalence of CagA antibodies by year of birth. On the x-axis, we have cohorts, and you can see over time that CagA antibody prevalence is declining among the white participants in these large cohort studies, but not among the Black, and that's creating an even greater disparity over time. But what important question is CagA associated with precancer, since we want to do cancer interception? So this is data that we got to work with the Linchu County study in Weichang-yu, as mentioned before, where they had endoscopies on everyone, and so we're able to look at all those elements along the CagA cascade. And you can see, especially for CagA, that when you go from superficial gastritis to chronic atrophic gastritis to IM to dysplasia, that you have increasing levels of CagA antibodies, again suggesting this could be a marker. So we wanted to ask, is CagA associated with gastric precancer in the US? And we've had a lot of conversations about how much can we import what we know in Asia to the United States and to different populations. So we were funded through a Cancer Disparities P20 at Duke, and we have a study called GRACE, Gastric Immune Response and Cancer Interception. And I co-lead the study with Katie Garman, who's a gastroenterologist at Duke. And she also co-leads the Cancer Risk Detection and Interception program with me. So I just have to call out our team. It's an amazing team. We couldn't do it without them. We just got the first male to our team this year. We're very excited. Getting some diversity. But really, it takes a large team, and I have to say the best part of it is the trainees. We have so many students coming in and out: medical students, fellows, undergrads, postdocs, and again, I work closely with Dr. Garman in running the GRACE team. So GRACE is set up if you take that CagA cascade and you just tilt it on its side, and we think about H. pylori, HP positive IM, and gastric cancer. We have a retrospective cohort from 2015 to 2019 where we took everybody at Duke who had a gastric biopsy and had one of these three conditions. And then we have a prospective cohort. So we've recruited about 320 people in the clinic who are coming in for an upper EGD and then taking fresh tissue samples. Katie's developing organoids. We get blood. And for both groups, we do deep dive EHR records and a survey. So I'm not going to show you the prospective data right now. We're working on that. I'm going to show you some retrospective data. So one thing that we wanted to do was, again, look at CagA. And I know we all know CagA, and it's really well established. My studies were all in serology. And as someone mentioned earlier, serology is, current, former. We can't separate those out. So we wanted to look at actually CagA in the tissue, right? So we used FFPE blocks and worked with Nina Salama at the Fred Hutch to look at CagA by race in North Carolina. So if you're not familiar with Nina Salama's ddPCR, her droplet digital PCR, it's really cool. She actually developed it for stool DNA, but she uses FFPE. I can use FFPE as well. Again, the idea being that it's a needle in a haystack. So for gastric FFPE, it's about 99% human DNA. So to find that little bit of H. pylori DNA, this droplet digital PCR is really good. So again, this is the kind of results they get. They're looking for the H. pylori gene, and then what you see down below is the fluorescence amplitude. And so, for example, here we see two distinct populations of droplets, one positive and one negative, but moreover, again, they're quantifying it, right? And so I think these are really interesting ways to think about who with H. pylori is at highest risk, who we should be intercepting their gastric cancer. So the first thing we were able to do is look at, among our two cohorts, H. pylori positive and H. pylori positive IM, we're excluding the gastric cancer cases right now, that there was a difference in the prevalence of CagA by ddPCR. So the IMs were much more likely to be CagA positive than the HP positives. And if we look at it by race, we saw a really significant difference. So 71% of our HP positive Black patients had a CagA, and only 32% of our white HP positive patients. And if we compare HP positive without IM and HP with IM, again, you see these same trends really high in our Black patients, starting to go up in our white patients. The other thing that's really exciting that Nina is doing is she's looking at HP load. And so load is still kind of a hard thing to estimate, and I decided that I felt most comfortable with load in quartiles, so I'm presenting it to you in quartiles. It is not normally distributed. But you can see that our CagA negative participants were more likely to be in the lower quartiles of HP load, and our CagA positive individuals more likely to be in the higher quartiles of HP load. And if we compare HP positive without IM to HP positive with IM, you see it's even stronger. In the CagA positive with IM, we're going to have the higher HP load according to Nina's assay. So again, while we're looking for interception, is CagA, I just don't think we should forget CagA yet. I really enjoyed Andy Chan's talk this morning. I think there are a lot of other biomarkers to look at. I think CagA is still really important and deserves our attention. And while I mentioned that I know Dr. Kumar had to leave for a meeting, I appreciated her pointing out our DISH study, but we have to do community engagement if we're going to do cancer interception. And so this is Bishop Ronald Godbey. He's the pastor of the church where we did our big DISH study, and it was supported entirely by our cancer center. And if you want to do community engagement, really work on your cancer center because it's hard to get NIH funding. You have to build a lot of preliminary data, and it's so important. And as Dr. Kumar mentioned, we talked about the issues she has in Miami versus those I have in Durham, North Carolina, and they're really different, equally really important populations. The other thing is to return results. I can't emphasize this enough, to keep individuals involved and caring and being educated about what we're doing. And finally, I'm super excited to announce we just got funding from the V Foundation. This is Jimmy V from NC State. We got the funding through SISUP, which is the Southeast American Indian Cancer Education Partnership, so that we're going to be able to do DISH H. pylori screening events in 3 American Indian tribes in North Carolina. So some final thoughts for you. So if clinical guidelines state that all active H. pylori infections should be treated, is there a role for CagA? So obviously, I agree that all H. pylori diagnoses should be treated, and I think this is happening in the clinical setting. But this is where, again, I think I have so much in common with Dr. Kumar. What about those individuals without symptoms? So they're not getting their H. pylori diagnosis, or without access to GI or specialty care. I can't tell you how many people in the community I see that tell me about their GI distress and they can't get to an endoscopy. Nobody wants to test them for H. pylori. Could we use CagA as a marker of increased gastric cancer or increased gastric precancer for population-based screening and treatment? Can we move it into the primary care population? I know we're going to miss some people, and I'm worried about them, like Toby Keith maybe didn't have CagA positive H. pylori, I don't know. And I'm not saying this is a perfect answer, but I think this is the kind of thing that we should think about. Another idea is, could we use CagA to stratify H. pylori positive patients for care and surveillance after their H. pylori has been eradicated? So we know that H. pylori eradication reduces your risk, and it does not, obviously, reduce your risk to that of someone who's never had H. pylori. So if you had CagA antibodies, it suggests you're at increased risk of gastric precancer and gastric cancer. Can we use that to do better surveillance, more often surveillance, again, put you on a higher risk trajectory? So either I spoke really fast, which is how I usually do, or I just didn't have that many slides, but that's it. Thank you very much.